Kia ora and welcome to Know ME, the podcast series where guest speakers talk about pressing issues surrounding myalgic encephalomyelitis, chronic fatigue syndrome. Join researchers, clinicians, and patient advocates as we take a deep dive into the most recent evidence-based information so that you too can know ME. In today's episode, we will discuss diagnosis of myalgic encephalomyelitis, covering criteria and the patient-centered approach. We're joined today by Dr. Rosamund Vallings and Dr. Sarah Dalziel. Dr. Rosamund Vallings has seen patients with ME/CFS for the past 40 years and been involved in writing management guidelines, lecturing, and research. She was awarded the New Zealand Order of Merit in 2008 for services to ME/CFS, and the Nelson Gantz Outstanding Clinician Award in 2016 by the International Association for Chronic Fatigue Syndrome. Dr. Vallings has written 3 books for patients and is a co-author of the International Clinicians Primer. Dr. Sarah Dalziel is a specialist general practitioner working at Te Ngai Medical Centre in Rotorua since 2001. Dr. Dalziel is a fellow of the Royal New Zealand College of GPs and enjoys all aspects of family healthcare with special interest in women's health and ME/CFS. She has attended several international ME/CFS conferences in USA, UK, and Australia. Dr. Dalziel is a medical advisor to ANZMES and has been involved in educational events for regional and national ME/CFS organisations and support groups. So kia ora and welcome. Haere mai, thank you both for being here today. In our first podcast, Ros, we talked about someone with ME/CFS and how they might present in clinic, with the key characteristic being post-exertional malaise, which we discussed in episode 2. So shall we start today with just describing some of the things a patient with PEM might say to their GP about their daily experiences and how they would articulate what is happening to them about how they are feeling?
Yeah, well, I think, many patients present with fatigue. There's no doubt about that in many diseases. But the characteristic post-exertional malaise that we're talking about today may not be what they present with. It may be as a result of some direct questioning, but they may well be, for example, a sports person who says, they can no longer play their sport as freely and easily because they feel this total exhaustion afterwards from which they don't really recover in a hurry. It's a very sluggish, slow return to normality, which they haven't had that problem before. So people with post-exertional malaise certainly don't recover quickly from their fatigue that they would in a normal way. But this doesn't necessarily mean that they are all going to present with post-exertional malaise. They will usually be presenting with the fact that I'm just terribly tired. And it's a direct questioning that may uncover the post-exertional malaise being the type of tiredness.
Exactly. I mean, so there's the types of things they're going to be saying is, I'm just so exhausted. I can't do what I used to do. Things like that. Sarah, armed with that information, what would a GP want to know next, and what types of questions should they ask their patient?
Yeah, so we just talked about post-exertional malaise, and that is a fairly a core symptom for ME/CFS and does help to differentiate it from other fatiguing illnesses. I think when we're thinking about ME/CFS, we're looking at that time frame of fatigue. So to make a diagnosis, you really need to be looking at somebody who's been unresolved fatigue for a long length of time. So generally it's over 6 months, but that's not to say we can't consider the diagnosis a lot earlier than that. So time frame, how it's functionally affecting them. So are they actually not able to do the same things that they did before? The other key symptoms that we're looking at are unrefreshing sleep and cognitive impairment. So patients will have difficulty describing that, but I guess most patients or most people can sort of understand this brain fog. Just can't process things the same, can't remember things, can't concentrate. Everything's just sort of a bit foggy. The other two other symptoms that are kind of really important to talk about would be orthostatic symptoms. So that's not just dizziness on standing up, that's generally worsening of symptoms with upright posture. And so some people say, well, look, if I just stand up all day or at the end of the day, everything's worse. So that those are the other sort of key questions. And then normally or usually there's a whole raft of other multiple symptoms which I just try to list. So you've sort of got a bit of an overall view on things, or sometimes just run through a quick systems inquiry, urinary tract symptoms, bowel symptoms, headache, pain, sore throats, that kind of thing.
Great, thank you. And obviously with the orthostatic or dysautonomia, there's a range, isn't it? There's some that might have hypertension and there's some that might go into the POTS, the tachycardia syndrome. And that's what we find with ME, that it's the two most commonly. Yep,
it's the dysautonomia is takes quite a long time to unravel sometimes and to get to the bottom of, but sometimes just in the initial brief history taking, just a general inquiry about dizziness, or how do you feel after you've been upright for a long length of time, can give you, palpitations, tachycardia, can give you a fairly good idea as to what's going on there.
What tests would a GP order?
Lots of the usual presentation to general practice, as we know, is that people come in and it's a very, very common presentation to say, I'm really tired, I'm tired all the time. And when that happens, the first, there's a whole raft of things that we want to rule out. And so your range of blood tests would usually, first thing is a blood test. So examination and then bloods. And that would include a blood count, renal function, liver function, iron, B12 folate, and then we would often think about rheumatological type things. If there's a lot of pain, we'll quite often do an ANA. If there's a lot of gut symptoms, we think about celiac and of course thyroid function as well. So most GPs will have a kind of a set of blood tests that you will do for fatigue, with the aim with ME/CFS is to ruling out other fatiguing illnesses, so that if everything comes back sort of negative or normal, that you can then start to narrow down that diagnosis. Other tests would be directed according to the symptoms that are presenting, which are wide-ranging. So that's where you may think about if you're presenting with a lot of gut problems, as to whether you need to investigate that further. And all GPs will be familiar with the kind of tests and referrals that you would need. If it's breathlessness and chest pain, then you would be referring accordingly, etc., etc.
Great. So we've previously discussed triggers. How important is it to address those triggers and treat the root causes of the illness that's potentially presenting as ME/CFS?
Well, I think the triggers are many and varied, and sometimes there isn't a trigger that you can actually focus on, but typically patients will describe having had maybe a viral illness from which they haven't recovered, or the trigger could be something like pushing themselves very, very hard at sport beyond what is normal common sense, or even things like a surgical operation or an accident or a vaccination. These can all be triggers that change the way your immune system works. And if you happen to be a person who is prone to developing ME, and this may well be an inherited trait, then this can be the trigger that leads to ongoing fatigue and the many, many symptoms that we see. Often these are people who are very high achievers, and they find it very, very hard to come to terms with the fact that they can no longer do what they normally would do or achieve in the way they would normally do, but not necessarily. I think it's fair to say that any person can get this illness. And, you know, we don't necessarily say, oh, it's only high achievers or people with very active lifestyles. Anyone can get the illness.
Absolutely. So in your years of practice, have you actually noticed that there is that common thread?
There's a common thread often. I mean, some patients straight away, you can almost begin to say, this is the sort of person who might get ME. But on the other hand, you do see many, many people who don't have those common traits. So I don't think there's any rule of thumb there or definite advice I could give on that.
So how many consults might it take to actually go through a process of differential diagnosis to eliminate or rule out other diseases or conditions that might have these same symptoms?
So, well, how long is a piece of string? Because I think, so I guess generally what we see is people don't generally come in and say, I've got fatigue and I think I've got ME/CFS. They come in and they say, oh, I feel really tired all the time and I don't know what's going on. And I have got an interesting stat here because fatigue affects up to 15 to 25% of the population at any one time. So an awful lot of us feel tired. Most of us don't have ME/CFS. And the study that I read said that, well, after 1 month, 8% of people still feel fatigued. And after 6 months, 4 to 5% of people feel fatigued. And that's kind of the group that we're looking at. So the majority of people in general practice who, as we all know, as GPs who present with fatigue, it's quite a lengthy process. So the history taking itself is usually at least one consultation to squeeze that all in, then usually sending away for bloods, come back and talk again, look at pertinent examination findings, maybe focusing on, we often are focusing on stress, anxiety, depression, what's going on in your life, and then looking at the individual symptoms and trying to unravel those. So, oh, you've got lots of gut symptoms, well, we better work that out first. So this takes, it's sort of like a timeline. We might be trying some treatments as well, so trying to improve sleep or that kind of thing, and then reviewing things as time goes by. So it takes time to sort of see what the trajectory is of the fatigue, but then also that repeated consultations to actually finally reach the conclusion, well, I don't think there's anything else going on. What could this be? Oh, I think this could be ME/CFS. So that can be probably 4 or 5 consultations to really get to the bottom of it. And I think the message, or the most important thing I would say to GPs, is just include ME/CFS in your differential diagnosis of fatigue. You know, if it occurs to you, or you think about it, then you can start to, you know, rule out other things and see whether they fit the diagnosis.
Right. It's actually a process of elimination, isn't it? Making sure there isn't anything more sinister going on, such as a cancer or gastrointestinal disease, and then coming all the way along to potentially an ME diagnosis. So what criteria would you recommend is used by health professionals to make a diagnosis?
Well, there are a number of different criteria that have been used over the last, 50 years for making a diagnosis of this illness, dating way back into the 1950s. But the one that seems to be simple for GPs to use and that has come to the fore in the last 10 years, probably 5 to 10 years, is the Institute of Medicine criteria, which one can download from the internet quite easily. And that's a very simple set of criteria. Some of the other sets have been very involved and time consuming, but this one basically has just a few definite things that need to be present, such as substantial reduction of impairment, inability to engage in pre-illness levels of occupation, etc., post-exertional malaise and unrefreshing sleep. Those are the three absolute criteria, and then at least one of either cognitive impairment or orthostatic intolerance. So that's a fairly simple, easy to follow set of criteria to make a diagnosis, and doesn't take too much time beyond what we've already covered today, which is the basic elimination process as best you can manage. So we use sets of criteria such as this, and this one has been accepted internationally and is used fairly readily now, and fairly simple too.
Right. So having a name for a set of debilitating symptoms can be really helpful for a patient. What else do you think is important?
I certainly think acknowledging that that the symptoms are real to the person and how debilitating it is. So I guess that sort of empathy for how the patient is feeling and how that's affecting them is really, really important. And I guess alongside that, then so offering support, but directing the patient to people who can help with that support. So support groups, education through ANZMES and that kind of thing can be really, really helpful to people. I think a lot of patients say, oh, thank goodness for that. I actually feel that somebody understands, has heard me, and I don't feel like a fraud.
ANZMES does provide brochures and packs for GPs. So do you think it's helpful for GPs to give patients written information for them to take away?
Yeah. Absolutely, definitely. I think, it kind of needs to be simple and nothing too bulky and which would take too much time to read through. So things like the ANZMES brochure, a very useful starter point for a GP, and it's something that can then be handed on to the patient.
Yeah, I definitely think either links to written information or brochures, because people find it really hard to absorb all the information in a consultation. We know that for everybody, they only get snippets of things, and particularly people with ME/CFS may not be able to concentrate for that long or find it very tiring. And so actually being able to go and read things, that also helps people who are maybe a little bit cautious themselves about having a diagnosis of ME/CFS, because they can go away and read up about what this illness is, and they think, oh, that really fits with me. Or maybe they come away and think, actually, that doesn't sound like me. Maybe I've got something else. And that can actually be very helpful. I would quite often ask people to do that, just to say, well, just go away and see if you think this fits with how you're feeling or your symptoms.
Absolutely, that's really important. And yeah, the written information helps, doesn't it, because they're already probably using their energy envelope just to get to the appointment, and then that brain fog starts happening during the consultation. So sometimes it's very difficult to keep all that information in the head. And Ros, I know you've mentioned previously that you provide a summary of the discussions to the patient so that they've got a record of what's been discussed between the GP and patient.
Yes, I think it's fair to say that most patients, particularly if it's a first consultation, may well not take in an awful lot of what one tells them because they're anxious and fearful and so on. And often if they've got some written information or a follow-up consultation, one can enlarge on what started off as fairly simple advice.
Yeah, and so we talk extensively in future episodes about symptom management. So for now, what is your advice to health professionals about tackling the many symptoms that are experienced?
Well, I think my feeling would be continuing to work on making an accurate diagnosis, because we don't want to cover up things that may be treated in a totally different way. So, constantly being alert to the possibility of, have I got the right diagnosis here, is really important. And then dealing with symptoms that are particularly prominent, such as pain, and sleep disorder, gut symptoms maybe, you kind of focus on what the patient is suffering from the most to give them some freedom from symptoms, and continuing always, am I on the right track? Have I got the right diagnosis? And I'll try and, help the patient with the symptoms, and maybe even by, for example, just treating their sleep disorder, you may find that many of their symptoms just disappear and you're on the right track, and perhaps it hasn't even been ME, or if it has been ME, at least you're dealing with a major set of symptoms which can give them a lot of relief and a feeling of confidence in both you as a doctor and their own understanding of the illness. They feel they're on the right track. But we must never shut our minds in any illness, really, to the possibility that there may be a different diagnosis, we're on the wrong track, or that the patient has more than one thing wrong with them. It's perfectly possible to have, for example, rheumatoid arthritis and a sleep disorder and ME, and they're all going to blur each other.
Yeah, and it's quite common, isn't it, to have comorbidities with ME?
Absolutely.
I certainly, we often start looking at symptom treatment and general advice while we're making a diagnosis, and a lot of that is fairly straightforward advice for people in terms of managing their stress, because we know that for lots of things that makes symptoms worse, but particularly ME/CFS, pacing activities, and as Ros mentioned, sort of the sleep side of things. And once again, it's sort of to do with that, how much time do we have in the consultation to cover this, all of these things. And so I'll quite often these days utilise our health improvement practitioner within the practice, which most practices do have access to now. And our health improvement practitioner is an occupational therapist, but she's excellent at talking to people about pacing, sleep, stress, but it does cover lots of other reasons why people might be fatigued if they haven't got ME/CFS as well. So it's a good way that people can get started on some sensible advice.
And I guess it makes sense to collaborate with the patient and see what is the symptom, the number one symptom you're feeling is the most debilitating, or the one that has the most impact on your life and your normal activities, and then try and see if you can manage that or treat that or eliminate that preferably. Is that the right approach, do you think?
Absolutely. It's quite a useful technique, is to ask people to bring their symptoms that are most debilitating for them or bother them the most, and we can treat those as we would, if people present with those. So if it's headache, we go along the treating headache type of guidelines. If it's bowel symptoms, then we can focus on that. So it's just simplifying it, because it is pretty overwhelming when people say, well, and I've got this, and each of their symptoms would take up more than a 15-minute consultation. So you do need to sort of be on the lookout for the more serious illness, as well as just trying to simplify. And a lot of the treatments actually are helpful for everything. So if you improve sleep, that's going to help with pain, that kind of thing.
I think also it's important to focus a little bit on the style of treatment that an individual patient might like. So some patients are very focused on wanting medication, and that may be entirely appropriate. Others don't want medication at all. There are some who like physio or would like to have some psychological input whereby they can address their stress depression, that kind of thing. So I think the style of treatment that a patient likes should be addressed as well. And sometimes you may feel, oh, that style isn't terribly appropriate for this patient, but, you know, let's go along with what the patient likes, and you're going to get a patient who's going to feel more satisfied, and at least they've tried something out that appeals to them, even if it hasn't helped them very much. I think your personal involvement in helping them along those lines is really important.
And it's great to be involving other modalities in the treatment plan as well, isn't it? So that it's a more
Absolutely.
holistic approach. Yeah. I mean, I think it's important to acknowledge that it can be overwhelming for the GP too, because there are so many symptoms. I mean, if you think about the systems that are actually involved here, the immune, neuroendocrine, sometimes cardio gets involved, isn't it? So yeah, so what advice would you provide a GP so that they can actually be confident in making a diagnosis of ME?
I think it's very hard to have an absolute rule of thumb there. I think there's no set plan. I think in many illnesses, and ME is no different to many other illnesses, you get a kind of gut feeling as if you're on the right track, and you begin to advise the patient along the lines of, you know, I feel this is ME, let's work on that area. And if the patient feels better as a result, well, at least you know you're progressing in the right direction. If, on the other hand, what you're doing for them hasn't helped at all, you've got to look at, first of all, is my diagnosis right? Is the style of what I'm advising this patient suitable? And so on. Medical consultations are most complicated, both in making a diagnosis and then formulating a treatment plan. It's never simple.
No, and particularly with such a complex condition as this as well.
I would encourage GPs to not be afraid of making a diagnosis, understanding that sometimes you get diagnoses wrong or something else becomes apparent, and that's the sort of ongoing care and ongoing thinking and investigation. You know, if symptoms are getting worse or there's new symptoms, then keep thinking about the other differentials, but also an understanding that other illnesses, comorbidities occur alongside ME/CFS. So you can have other things such as irritable bowel syndrome or hypertension or ischemic heart disease and have ME/CFS. And I guess that is the skill of that doctors have, and particularly GPs, is we are actually used to managing multiple comorbidities in any one patient. So it's about thinking of the diagnosis, seeing whether they fit a diagnostic criteria, and being not being afraid to make a diagnosis, because that may be very helpful for patients to have that diagnosis and support, and it can always be reviewed.
I think another thing that, you know, we can move on to always is referring the patient on. If we feel not confident about the diagnosis, or it's a very complex kind of story, then we've certainly got the option to refer the patient on to a relevant specialist, such as a neurologist, to make sure we're not looking at a neurological disorder, or a gastroenterologist, and so on. So we need to be confident to refer patients on, but that can often involve a long wait time. And so we need to be in a very supportive role during that wait time and use other personnel within our own medical practice too, such as practice nurses and physios and people who can talk to the patient in an understanding way.
Absolutely. Well, ngā mihi, thank you to both Dr. Rosamund Vallings and Dr. Sarah Dalziel for being with us here today for this episode of No ME. It has been a useful discussion on making a diagnosis, and we thank you both for providing us with your wealth of knowledge and expertise. Thank you.
Thank you.
You've been listening to or watching an episode of No ME, a place for you to hear the most up-to-date, evidence-based information on ME/CFS. Thank you for joining us.